Well, hello and good evening, everyone. And we really appreciate your time. As Karen said, I'm Sharon Moore. I'm here with Hope Nelson, fellow detailer, and here we're going to talk about maternal care, breaking trauma cycles, and simultaneously nurturing resilience and well-being. Hope and I had so many talks about what to include here, and then, of course, what had to be left out. She and I will have these conversations with the milkman given the opportunity. We're both very, very passionate about this material. Um, so there were things that were left out because within this 1 hour presentation, there were so many different pieces that could have been blown out into their own 1 hour programs. So we sort of settled on a kind of a high level presentation, and we're leaving everyone with some great resources and tools. First up, we have no disclosures. I think everyone has seen our objectives. So let's begin where really we always have to begin, and that is with stigma. Now, this is not published work, but One Tennessee strives to be data-driven in our actions and initiatives. This survey was completed by an intern, so let's just look at it together. In a recent community survey of 39, One Tennessee asked individuals about their experiences and perceptions regarding stigma and substance use disorder. Here's what we found. 96% of respondents with lived experience, either personal or through a loved one, believe people with substance use disorder are treated unfairly by society. And then those with lived experience are over 8 times more likely to recognize stigma compared to those without it. So let's just stop right there and sort of sit with this for a minute and really think about what we can do. 8 times more likely is a remarkable gap that somehow we've got to figure out how to bridge that, getting people with lived experience to give us feedback, to make sure people with lived experience are part of our program development or program evaluation. But the 8 times more likely just indicates to me there can easily be levels of maybe even unintentional blindness. But that said, we really have to actively take steps intentionally to try and see that which we don't easily see. So, one of the many issues that stem from stigma is that it leads to non-treatment, and that leads to its own set of issues. So, here's one example, and it's from the Tennessee Department of Health. From 2017 to 2021, Tennessee Department of Health reported a 227% increase in congenital syphilis cases, with over 60% of preventable congenital syphilis infections in Tennessee were among women with no or late prenatal care. And I looked it up. As of 2024, the surge continues. I mean, the first time Hope and I heard this, we were floored. I actually sort of thought we had moved past this horrible and preventable disease. So we made a point of trying to work it in anywhere we can to try to help get word out. Now, I don't know how many here may have seen this documentary about stigma and the discrimination of substance use during pregnancy. This film was created with the goal of improving care. If you've not seen it, we highly recommend it. It is just so powerful and well done. And you've got a QR code, they'll get you right there. So we're going to move into the next section and begin with just a few definitions. And Hope and I really don't want to spend too much time on what many here may already know, but we have found just taking a few minutes to do a quick level set gets us on the same page and helps make conversations more impactful. So first up, what is trauma? Trauma is defined by SAMHSA as an event, series of events, or set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening and has lasting adverse effects on the individual's functioning, physical, social, emotional, or physical, spiritual well-being. It sort of has these three E's, if you will. There's an event, it's experienced, and it has effects. Regarding social determinants of health, there is a large and compelling evidence, a body of evidence that has accumulated, particularly in the last 2 decades. The evidence does not deny the importance of medical care influences toward health. Rather, it indicates medical care is not the only influence of health and suggests the effects of medical care delivered in sort of our classic hospital and clinic settings may be more limited than commonly thought, particularly in determining who becomes sick or injured in the first place.
And most of you are probably familiar with this graph. You've seen it Healthy People 2020, Healthy People 2030. Um, but it's easy to see it and think that so many things just fall outside of our lane in healthcare. But when we think about it, the new AHA's Prevent Risk Calculator for CVD, atherosclerotic heart disease, heart failure. It includes a place to put in the patient's zip code. That's a way for us to incorporate the social deprivation into the actual calculation for their overall risk of disease. So if I see, a middle-aged patient with diabetes and high blood pressure, I enter the usual clinical data, their SBP, their total cholesterol, all those things it asks. Also, I think it asks for an A1C that you can optionally put in. But you can also now put in the zip code. So now I, as a provider, can better understand how the neighborhood level disadvantages that my patient may be experiencing are influencing their risk. So it helps us move beyond treating the numbers alone. It reminds us that, prevention is not just telling them to eat better or exercise more, or it's not just starting a statin based on their risk score. So if we can, using evidence-based guidance, and we can intentionally expand our care into these other health behaviors, we can also expand our zone of influence and, improve health outcomes and all that, those kind of things, but still staying in our healthcare lane.
And that is where educating patients on adverse childhood experiences and or positive childhood experiences can help. I actually hear Hope say it all the time. Through this education, we are planting seeds. Sometimes they are the tiniest and babiest of seeds that ever were, but they are being planted. And here you have a QR code that will get you to that updated American Heart Association's Prevent Risk Calculator in case you've not received it yet, because I hear it just came out. So what are ACEs? ACEs are adverse childhood experiences that are traumatic or stressful events that occur between the ages of 0 and one's 18th birthday. One of the aspects that differentiates ACEs from stress and trauma from general stress and trauma is that these events occur specifically in that window of time between 0 and one's 18th birthday. So ACEs are a subset of stress and trauma. ACEs are linked to and have a dose-dependent relationship with many physical and behavioral health conditions, including many of the leading causes of death. And you see this, how many it contributes to, ranging anywhere from 5 to 9, depending on who's doing the citing. There is an ACE questionnaire or screener that consists of 10 yes or no questions that was derived from that mid-1990s landmark Kaiser Permanente study. When one takes the questionnaire, it's a number of yes replies that represent one's ACE score. And just as a note, it is increasingly held that many adult diseases should be viewed as developmental disorders that begin earlier in life. But there's a few notes of consequence regarding ACEs. I mean, first of all, they are incomplete in capturing childhood trauma. That study we're working from is, back in the 90s, and we now know there are many stresses and traumas that children experience beyond these 10 yes or no questions. So to be sure, there is and should be much more work done in this field. We do use ACEs because it has stood the test of time and been standardized into outcomes as a way that makes it a great starting place. It is a great practical, evidence-based, time-sensitive tool that any practice can incorporate into the entirety or some aspect of their practice.
Yeah, so what we do in my office is we do mainly pediatric ACE screenings, preventing or catching on to issues before they have become this like lifelong traumatic um, outcome potentially. So we do the ACE screening starting at our 12-month well child visits and just do at the yearly from there on. And then I've never had any pushback from any parent at a well child. They're already filling out, pages of ages and stages and all the bright future yes or no's. So 10 more questions to them that they circle is nothing. Um, in adults, I usually use it in people who we've been trying to find them like the right combination of depression medicine or something like that. Like maybe why aren't we getting, what else is hindering us here? What other things might be impacting this besides, just needing an SSRI or something? Um, we, of course, like do the PHQ-9, GAD-7, all that, but and those are great. They give me current data, currently where the patient's at. But if I add the A screen, it gives me context to the data. Um, so that's why we like to do that there. And then in prenatal care, we don't do a whole lot of that in my office, um, but we do see a fair amount of like pregnancy confirmation, that kind of thing. And so while I don't do like a formal screening, we do kind of assess for prior adversity, current stressors, mental health concerns, safety needs, things like that at that time.
So ACEs data is population level data and does not necessarily hold up at the individual level, and it is never considered diagnostic. I mean, humans are complicated, really complicated, and much, much more complicated than some single number. And then one final point, we always really try to emphasize that when we're talking about ACEs, is that we know many of us here do have ACEs. So anytime talking about ACEs, we always remember that we're potentially bringing to mind the person's difficult childhood memories. So we always talk, tread lightly when talking about ACEs. Uh-oh. Well, I clicked on the other screen. So there we go. Okay. So we're just going to briefly explore and define stress or the stress response, remembering, of course, that not all stress is bad. In fact, a certain amount is beneficial. There are three types of stress response: positive, tolerable, and toxic. Positive stress, also referred to as eustress, is brief elevations in stress hormone, heart rate, blood pressure in response to a routine stressor. Think of a test or a game. Tolerable stress is a time-limited activation of the stress response that, if buffered by relations with adults who help the child adapt, the brain and other organs can recover. You can think of a natural disaster in that situation. Toxic stress is high doses of adversity experienced during critical and sensitive periods of early development without adequate buffering protections and can result in lasting consequences leading to the toxic stress response. The extent to which the protective adult relationships facilitate the child's adaptive, coping, and sense of control can make an impact here. shifting what might have been a toxic stress response into a tolerable stress response. So, toxic stress is the most dangerous of the stress responses experienced by the child who is lacking adequate buffering. Evidence is demonstrating that toxic stress can lead to long-term changes in the structure and functioning of the developing brain, metabolic, immune, neuroendocrine responses, and even the way DNA is read and transcribed. It is the plasticity of that young brain and how rapidly it's growing that makes it so vulnerable to stress.
And if children feel safe, they take risks. That's why my 1-year-old, when she's with me, thinks she can climb up the bookcase or whatever it is. Or if we're out walking around, she's willing to take those extra to risks because she feels safe. It They can ask questions. They feel comfortable to ask questions. They feel comfortable to make mistakes and fall down, and they learn to trust and share their feelings and grow. And when they don't feel safe, when they have that toxic stress, that's when they shut down.
Hope actually reminded me of a really kind of tidy catchphrase here that really captures the gist of what's going on here. Our children, we can't thrive and survive at the same time. When the young brain is focused on survival, learning, growth, and connection just have to take a back seat. And so as it happens, the stress from ACEs is capable of inducing a toxic stress response. ACEs are grouped into three domains. There's abuse, neglect, and/or household challenges. So, okay, on this slide, we have a list of identified adult ACE-associated health conditions and their odds ratios. We're not going to linger over this page and don't even try to read it. We just really wanted everyone to see how extensive and long this list is. There is one number that we'd like to call out because it is relevant to our talk tonight, and that is the next to the last one there. You see violence victimization, which includes intimate partner violence and sexual assault, with an odds ratio of 7.5, meaning that if we compare an adult person with a score of 0 to an adult person with a score of 4 or greater, that person with the 4 or greater is at 650% increased risk of experiencing violence victimization. Oh, just making sure there's no emergency there. Um, Now, I don't think I mentioned it earlier. It is at a score of 4 or greater that the risk really stack up against a person. So you'll frequently, not always, but frequently see 4 as the benchmark for concern. And this chart is identified pediatric ACE-associated health conditions. Now, if you look down that middle column, you'll see they're not all 4s, and that's what we were talking about earlier, was there's sometimes it's 3, sometimes it's 4, mostly 4s, sometimes it's 3, sometimes it's 5. Once again, just don't try to read the slide. Just really want everyone to see how extensive it is. But once again, there is a number here that we would like to call out, and that's that very last one of teenage pregnancy with an odds ratio of 4.2. And so in that case, we're looking at a girl child with an A score of 0 and comparing her to a girl child with an A score of 4 or greater. And the girl child with the 4 or greater is at 320% increased risk of experiencing teenage pregnancy. And then we have 3 more charts with other ACE-associated health conditions, and these center around OBGYN care and concerns. On this one, you can actually see teen pregnancy and teen paternity called out there. And so the second and the third. I showed you all these because that makes it as something like 60 to 70-ish behavior and health consequences that are impacted by ACEs. That's a pretty remarkable number to me. So let's look at ACEs and their impacts in a different way. And let's be clear, there's still a lot to learn about ACEs. Um, and I think you're actually going to hear us say that several times. There's just still a lot to learn about some of these issues, including causation and correlation. As an example, if a girl child is at, or a girl, a female, is at risk for unsafe sex, she is also at risk for STIs, and she is also at risk for unintended pregnancies. So these are not discrete, but they're all recognized risks nonetheless. And then these are some graphs we pulled out of the ACEs Too High website. We've included smoking there. You see it there in the middle, and then next to it is knock-on risk of COPD. Also included here, we've got depression, alcohol use disorder, perpetrating domestic violence, later being raped, suicide, and others. And each of these graphs demonstrate that dose-dependent relationship they have with ACE scores. And the very remarkable assertion that having an ACE score of 6 or greater decreases life expectancy by 19 years. And it's very easy to think that that decrease is due to risky behaviors, but it is not exclusively risky behaviors that lead to that decrease in life expectancy. And then a piece of data taken right out of Dr. Vincent Felidi's 2004, The Origins of Addiction, Evidence from the Adverse Childhood Experiences Study. This is a really great paper. If you've never read it, I highly recommend it. There's just so many pearls and really great clinical points that can be like plucked right out of this thing. But here's one. I'm just going to read the excerpt. For instance, a male child with an ACE score of 6, a male child with an ACE score of 6, when compared to a male child with an ACE score of 0, has a 46-fold or 4,600% increased risk in the likelihood of becoming an injection drug user sometime later in life. And let's all remember this population level data that the 4,600% may apply to the individual, whereas it does apply to a large population. And then sort of taking this a step further and maybe even risking gilding the lily a bit here. But when we help folks reduce the ACE score of their kids by even just 1 point, that can translate into real life benefits. And then thinking of the adage, common things are common. A few points to consider here. 52% of us, of Tennesseans, have an ACE score of at least 1. Put that another way, that means the majority of us have experienced a significant stress or trauma prior to our 18th birthday. More than 2 out of every 3 of us will have exposure to a traumatic event during the lifespan. And then that last box over to the right, the disturbing report that interpersonal violence is more common in birthing people than gestational diabetes. So let's just sit with that for a minute and ask ourselves if we're addressing this with our pregnant patients. And let's also remember and wonder how this may be playing a role in the in the cycle of trauma that some families really struggle with. And we might ask ourselves, what could I possibly do about that? Well, the answer is, at a minimum, we can plant seeds. There is a paucity of large studies here, but there's an emerging understanding that matrescence is a recognized brain remodeling and neuroplasticity that is orchestrated by a flood of pregnancy hormones to prepare the mother for motherhood and aid in bonding with her infant.
Yeah, and pregnancy drives, significant lasting changes in the brain. And that makes the pregnant person more open to new information and new behaviors. It's opens a window of opportunity when these individuals are particularly likely to be open to support behavior change and health promoting interventions. Pregnant people are often highly motivated to start to adopt healthier behaviors and are more receptive to this kind of information, this kind of education. But there are real challenges to lasting change. If we are going to bend the arc toward better health and well-being, we have to understand that opportunity and motivation may not be enough. We have to provide education to aid them on their journey to healthier behaviors. And we also have to understand that lasting change requires access to resources that some people do not have, supportive environments, which also some people do not have, and consistent, compassionate care, which we can hope they do have with us. So, as clinicians, how we show up during this period matters. This is a time to educate, a time to support, and a time to partner with pregnant individuals and not just provide them the same information.
So this slide attempts to demonstrate why the care of birthing people holds unique opportunities to interrupt this cycle of trauma and ACEs. Without education and support, the cycle can just as easily go unchecked. Moms impacted by ACEs can give rise to in utero exposure of toxic stress, have bonding difficulties with their baby, and there's the risk of the child experiencing their own set of ACEs, bringing us back around to another generation with ACE impacts. Excuse me. So I think it is easy enough for us to envision if mom is in a low stress or even occasionally a positive stress environment with prenatal care, what's happening to mom is also happening to unborn baby. And so the opposite is also true. If mom is in a highly stressful environment for any number of reasons, we can envision that impacting the unborn baby, right? We can see the genetic potential and the lived environment work together, beginning even before birth. And also remember, within that unborn baby, future reproductive cells are already being formed. So we could reasonably expect what's happening to mom can also impact the grandchild and even future generations as it happens. The impact to the unborn baby and next generation is intergenerational. The impact to generations beyond the grandchild is transgenerational. It is a little bit different from the dads. You'll be able to see from the notes. I didn't go into it because that's a whole other side. That's a whole other rabbit hole to go down. But it's the first and second generations that are intergenerational, and the transgenerational are the generations who are not exposed to the initial trauma.
And I would just add, that nature and nurture right here are not separate forces, right? They kind of work like a tapestry, like the fibers they run in different directions, um, but they only really become whole once they're woven together. So, in the same way, biology and environment, they're constantly interacting with each other. And then the epigenetics helps us understand how those threads are woven together across generations and generations and generations.
And then one more thing before we move on from this slide, I think it is just super important to keep in mind that while it is easy to think that all the effects of maternal stress having negative consequences on future generations, but that does not have to be 100% true. In fact, it is highly unlikely that that is the case. There is just so much we don't know, and these studies are difficult for so many reasons. Funding and isolating, they're so impossible to do. But the thing to keep in mind is epigenetics seems to be a way biology has created to transmit information about what an organism is experiencing today to future generations. And we do generally hold that biology loves and rewards resilience. Epigenetics is a study of how environmental and behavioral influences cause heritable change without altering the DNA sequence. An epigenome is a collection of the epigenetic marks on a DNA in a cell. Different cells, blood cells, bone cells, muscle cells, have different epigenomes. When epigenomic compounds attach to a DNA strand, it is described as having marked that genome. These marks do not change the sequence of the DNA, but these marks do change the way the cells use the DNA information. These marks can survive cell division and can be heritable. And an epigenome can be dynamic, it can change over time. Epigenetics is exploring the switches that turn gene expression on and off, referred to as an epigenetic mark. One such epigenetic mark is methylation. Methyl groups attach to sites on DNA and act as a kind of roadblock, altering transcription. Increased methylation generally impedes RNA transcription, while decreased methylation is the opposite. Methylation changes also endure normal cell division. In in our last slide, we talked about the epigenome being dynamic. There are a few studies showing healing at the epigenetic level. So what influences an epigenome? And then what can we do about that? Once again, there's a lot we don't yet know. And in no way do Hope and I represent ourselves to be some sort of epigenetics experts, because I assure you we are not. But research is showing us that epigenetic changes are involved in our metabolism, inflammation, substance use disorders, asthma, autoimmune disorders, cancer, the aging process, and diseases associated with aging.
We can't choose the genes we're born with, and we can't control so many, aspects of this world. But maybe what we can do is use this growing body of work and research to nurture healthier epigenomes. Some examples could be, just the food that mom eats while pregnant. Mom's health and well-being just generally while pregnant. Infant and toddler nutrition, adverse childhood experiences, like we mentioned, exposure to toxins like cigarette smoke, use of alcohol, the food we eat right now as adults, our level of daily stress in our life, on and on and on. And if experience can shape biology, then creating a healthier, safer, more supportive environment may be actually one of the most powerful tools we have in order to, you know, work and nurture this healthier future.
So let's take a look at a couple studies. First up is Project Ice Storm. In January of 1998, 5 days of freezing rain collapsed the electrical grid of the Canadian province of Quebec. The storm left 3 million people without electricity from anywhere from a few hours to 45 days. It was one of the worst natural disasters in Canadian history. I mean, living without electricity in the middle of a Canadian winter, well, that would be stressful to anyone. I can't even conceive of it, actually, and potentially life-threatening. Nearly 200 women who were pregnant during the ice storm were recruited for Project Ice Storm. The moms completed questionnaires to measure the objective severity of the hardships they experienced. Think of the number of days without electricity, financial loss, injuries, moving house, and so on, and also how much subjective distress they were feeling from the disaster. The study is revealing that the women's objective level of hardship from the ice storm predicted the children's epigenetic profile, while the mom's subjective level of distress from the storm didn't predict effect. The changes in the kids weren't due to their mother's degree of emotional distress from the ice storm, but rather to factors outside the mom's control. Again, like such as days without electricity. Objective severity most affected methylation of two kinds of genes in the ice storm kids: immune genes, which may be increasing risk of asthma and allergies, and metabolism genes involved in obesity and diabetes. Data continues to be collected from this event, this project, including how the Y and X chromosomes are playing a role in outcomes. If you're unfamiliar with the study, it is absolutely worth a look. And I think it's just really important. This study really underscores what Hope said a few minutes ago about there are so many aspects of the world we cannot control. But at least in regard to prenatal care and pediatric care, it does show me that we should try and control some of the controllables. And then we have the World Trade Center. And so after the Twin Towers collapsed on September 11, 2001, clinicians offered to check anyone who'd been in the area for exposure to toxins. Among those who came in for evaluation were 187 pregnant women. The women were monitored through their pregnancies and beyond. When the babies were born, they were smaller than usual, the first sign that the trauma of the World Trade Center had reached the unborn baby. 9 months later, 38 of these women and their infants were examined during a wellness visit. Psychological evaluations revealed that many of the moms had developed PTSD, and those with PTSD had unusually low levels of cortisol, a feature researchers are coming to associate with the disorder. The saliva of the 9-month-old babies of the women with PTSD also showed varying degrees of low cortisol. It had been assumed that low cortisol levels had something to do with being raised by parents who were suffering from the long-term emotional consequences of severe trauma. Now it's looking like this trauma could have left this trace on the offspring even before they were born. To the best of my knowledge, this study is not ongoing. Excuse me one second. I think this graph really does a great job of reminding us that our 10-year-old self has exactly the same DNA as our 40-year-old self, while allowing for the effects of epigenetics through different environments and behaviors to potentially bring about different outcomes to that 40-year-old. So, can a person positively influence their epigenome? I mean, if it can be negatively influenced, then surely it can be positively influenced. But there is no single clear roadmap for this at this time. Scientists believe certain choices can support positive epigenetic changes and lower the risk of harmful changes. Once again, you hear these same things, eating nutritious food, building physical activity into the day, limiting alcohol, avoiding tobacco products, and trying to manage stress. The epigenome is, in fact, more open to change during the earliest years of life, but for all of us, it's never too late to start. And then allostatic load refers to the cumulative effect that chronic stress has on mental and physical health. It refers to the wear and tear that on the body that life events and environment stressors uh, create. When events occur that exceed an individual's capacity to cope, allostatic overload may occur. Allostatic load is sort of described as the price we pay for adapting to stress. It is meant to measure the biological consequences of prolonged stress. Over time, the repeated activation of the stress response can dysregulate systems such as cortisol, blood pressure, glucose metabolism, and inflammation, which can lead to cardiovascular disease, diabetes, depression, adverse pregnancy outcomes, and earlier mortality. So, allostatic weathering is referring to the physical wear and tear, including premature aging, that accumulates due to chronic exposure to social, economic, and political stress. It helps us understand how chronic exposure to systemic stressors such as poverty, discrimination, and structural inequities can become biologically embedded over time.
Absolutely, stress can leave a mark, but so can care, connection, stability, all those other things that we were talking about.
Yep. So, with that in mind, let's think about these 20 dark red rural counties we see on this chart here of Tennessee. And here we're going to look at that second one from the left, poverty rate at 18.4 in those rural counties. Viewing this data from the lens of our earlier points, we have to wonder at the well-being consequences for the people of our rural counties with nearly 1 out of 5 living in poverty. And then the next graph the over to the right, child poverty rate at 23.9 in those rural counties, with nearly 1 out of 4 of our Tennessee children in those 20 counties living in poverty. What is the cost to that child? And what is being passed down from generation to generation? It is reported statewide in Tennessee that 951,400, or nearly 1 million of our 7.23 million Tennesseans, meaning like 1 out of every 7 or 8 of us, are living under poverty. And then, if all that weren't enough, we can add care deserts to the challenge. And that is where your organization, Karen, just comes into play. So important, reaching out into every corner of Tennessee. Um, so 36.8% of Tennessee counties are deemed maternity deserts. So it is time to shift the paradigm and start asking ourselves what happened to the person instead of what is wrong with them. And this is a way of seeing patients through a trauma-informed lens. And I think it really also ties back to the American Heart Association's updated calendar, recognizing that zip code is impacting what's happening to the person instead of just what's wrong with them. So let's sort of take a broad brush at trauma and healthcare. So we have established that a history of ACEs is associated with many health problems, including those specific to women in pregnancy. And then we say healthcare services can be re-traumatizing. I'm just thinking about the girl, the woman who is living in some sort of distressing home, violent, unsafe, and then I'm imposing her in OBGYN care, and I'm thinking about those gowns and those bright rooms that are cold and the news blaring. So we can absolutely say that prior trauma influences how we engage with care, up to and including avoiding care altogether. So, what we're looking for is consistently compassionate and attuned interactions with all staff to promote feelings of safety and security, which is critical for the recovery of those who have experienced trauma. And by that, I mean everyone from the security guard in the parking lot to the person answering the phone to the person checking them out and everyone in between. So let's talk ever so briefly about trauma-informed care. Now, there is a wealth of information regarding trauma-informed care at SAMHSA. But trauma-informed care does not mean being a trauma therapist or even a trauma expert. There are everyday ways to bring about a more trauma-informed shift to our practices. So let's talk about that. Safety. Ask the patient if there's anything you can do to help them feel more comfortable, and always ask for permission prior to making physical contact. Trust. Tell the patient what you are doing and why you are doing it. Peer support. Ask the patient if there's someone they would like to have in the office with them. How are we doing on Hope? I just remembered. Oh,
Good.
okay.
I think so, based on your.
Oh, I better get going, looks like. Collaboration. Ask the patient about any past experiences they would like you to know. Empowerment. Ask the patient to tell you about what would help them feel more comfortable. And then cultural issues. Ask the patient what name they prefer to be called. Using these everyday ways of trauma-informed care enables the office to become part of the ecosystem of safety and resilience for the patient. Her world may be chaotic, but in your office, she can feel safe. She can embody the feeling of safety while she is with your team. And that is one of the controllables. So let's talk about resiliency building for just a minute. And I'll be honest, it wasn't all that long ago that I really thought of resiliency as being sort of a static, baked in feature to an individual. But as it happens, it can be taught and learned. The stronger the resilience of the individual or community, the more quickly they can bounce back after difficulties. An acronym to help us remember some ways is Resiliency Saves.
The S being social connection. Biologically, we need connection. It helps with the release of oxytocin and dopamine. And then attitude is the A, reminding ourselves that the current situation isn't permanent, and that the current situation isn't going to go on forever. I have a toddler. If you have a toddler or a toddler in your family, you're probably familiar with Miss Rachel. And in her lyrics to the song I'm So Happy, she says, "My joy is in the way I choose to think." And I listen to that multiple times a day. So that mindset can be taught, and it's being taught to our youngest of youngest already, building that resiliency. So if Miss Rachel is out there teaching it, we can too. And then values for the V, finding your meaning and purpose. And then E, emotions. Many of us have probably heard name detainment, and it is true that being fluent in your emotion words and knowing how to name the emotion can help us regulate and manage them more effectively. Learn, teach, model resilience building to your patients. If adversity can echo across generations like we've talked about, then there's no reason resilience can't either. It's designed to. Science is teaching us that we are less vulnerable to stress, even toxic stress, when we have these high levels of resiliency.
So let's talk about high levels of resiliency and pregnancy. It is associated with it is associated with lower rates of stressful events. Let me take a sip of water. Stressful events during pregnancy, including helping mitigate the relationship between traumatic experiences and multiple adverse outcomes, such as depression, substance use disorders, PTSD, and suicidal behaviors, lowering rates of postpartum depression and PTSD, supporting maternal self-efficacy. What is maternal self-efficacy? You may be asking yourself. Well, it is a mom's belief in her ability to succeed in the parenting role. It is her confidence in her ability to handle the demands. It is not some sort of general feeling, and it is tied to her perceived ability to perform specific tasks such as caring for the baby and reading their cues. The higher the self-efficacy, the more positive the experience. So in this next little section, we're going to just share some resources that we really hope you'll want to be curious about and check out. So first up is Maternal Health Matters. We love this newsletter. I'm always going to it to find new resources and data. So if anyone cares for pregnant people, we highly encourage you to subscribe to this newsletter.
Pregnant people or people that can become pregnant, I like to say.
There you go. Well, yes. You've got some QR codes to get you to more information about trauma-informed care. The one on the left is SAMHSA and just fabulous information. The one there in the middle, key ingredients. I don't know about you, but sometimes I just need some bullets. And then over there on the right, One Tennessee created a brief trauma-informed video. I think it's like 90 seconds. So we have known for a long time that these stress busters, quality sleep, balanced nutrition, physical activity, mindful practices, experiencing nature, mental health care, supportive relationships are part of healthy living. And now we know they are evidence-based. Utilizing them can help us avoid ACEs in the first place for our kids and can decrease the consequences for those who've already experienced ACEs or trauma. While you can never take an ACE back, you can help bring healing to the individual. So once again, learning, teaching, and modeling these stress busters supports patient empowerment. And that QR code will take you to the the public facing piece within ACEs Aware toolkit. And in there, you'll find all kinds of information, pages you can print out, worksheets for patients, and it's all for free. And PCEs, or positive childhood experiences, or PACEs, are sort of the other side of the experiences coin, but these are protective compensatory encounters. They promote safe, stable, and nurturing relationships and build resilience. And we remember that build resilience helps support us and to bounce back after adversity and makes us more able to withstand stress, even toxic stress. I'm really coming to see PCEs as something caregivers can give their children no matter what. As an example of what I mean, no matter what county you happen to live in, even those 20 dark red ones, PCEs are still something we can give our kids. And remember, now this is evidence-based. We clip this right out of the Tennessee.gov. So let's just walk through it real quick. And remember, these items are things that the child actually feels as an embodied experience. They are not the protective factors we've been reading and hearing about for some time. Now, protective factors are important, but PCEs are not merely the child having a loving and supportive family, but rather the child translates that into a feeling of being safe or embodying the experience of feeling safe. So let's just run through these real quick. I was able to talk with my family about my feelings. I felt my family stood by me during difficult times. I enjoyed participating in community traditions. I felt a sense of belonging in high school. I felt supported by friends. I had at least two non-parent adults who took a genuine interest in me, and I felt safe and protected by an adult in my family. These build resilience and build those relationships that are just increasingly valued in the care of our kids. Here is a QR code that will get you to more information. Um, we have a community compass. I don't know if everyone's familiar with it, but this is a free resource that practices and individuals can use. And then here is a QR code to get you to the ACEs Aware toolkit that will have practices able to do screenings successfully. Our QR code. So what can we do? Let's plant those seeds. Teach patients, parents, and caregivers about ACEs. Teach patients, parents, and caregivers about PCEs. So important. And then if you can, screen for ACEs and or PCEs. And I think we have at least a couple minutes for questions. Thank you for your time.
All right. Thank you so much. That was a great presentation, Dr. Moore and Hope. Just want you all to know that the slides will be sent out with your attendance certificate, so you will have those resources available for you. Do we have any questions for our speakers before we head out? You can either unmute or put something in the chat. All right. I'm not seeing any. Um,
Oh,
all right. So
wait,
I'd like to thank you all for attending tonight. Please be sure to complete the
Sharon.
webinar evaluation. Oh, do we have
Wait,
one?
I think we do.
Okay.
I had a question. Can you hear me?
Yes.
Yes.
I'm curious, the impact of women that bearing children, but it's an unwanted pregnancy,
Oh,
and how that bears into subsequent ACE, etc. Is there any data on that?
I don't know of any particular data, but I just can only imagine. Hope, do you have any thoughts on that?
I haven't seen any data, but I can imagine that just extrapolating out, if deter the circumstances of an unwanted pregnancy, right, are probably built upon a foundation of trauma, some potentially. And so I can see there being definitely a correlation.
It's a great point. We'll take a look, and if I can find anything specifically about it, we will forward it along.